Hello, my dear. I'm Dr. Alaa Mosbah, Professor of Obstetrics and Gynecology, Faculty of Medicine, Mansoura University. Today we have a very interesting case. This case scenario about menarche never come. Okay, let us start this case scenario. A 23-year-old female present with abdominal distension and primary amenorrhea. She is 150 centimeter in height and 51 kilogram in weight, and without a notable medical, family, or psychological or psychosocial history. She didn't consume alcohol, tobacco, or any drugs. The patient was examined at the age of 18 at a gynecology clinic for primary amenorrhea and was diagnosed with acyclic amenorrhea without further tests being conducted. Afterwards, the patient underwent no treatment. Afterwards, the patient underwent no treatment and didn't experience menstruation. Upon examination, a 15 centimeter tumor was found in the pelvis. The inspection of external genitalia revealed clitoral hypertrophy and the narrowing of the vaginal opening. Pelvic magnetic resonance imaging revealed a tumorous lesion in the pelvis measuring 15 by 14 centimeter, solid and cystic components. Also, enlarged abdominal para-aortic lymph nodes, and the uterus couldn't be found. Blood tests revealed the following levels: FSH 53 milliunit per milli, LH 36 milliunit per milli, estradiol less than 10 picogram per milli. Serum beta HCG and lactate dehydrogenase and CA125 were elevated. So this is our case today. Again, it's a very interesting case. She is 23-year-old. She has a short stature. Her height is 150 centimeter. Her weight is 51 kilogram. She was examined at the age of 80 at gynecologic clinic because of primary amenorrhea and was diagnosed with acyclic amenorrhea without further tests being conducted, and she didn't receive any treatment and the menstruation never come. So menarche never come. Later on, when she presented with abdominal distension and primary amenorrhea at the age of 23, on examination, pelvic tumor was discovered about 15 centimeter. Local examination, inspection of the external genitalia revealed clitoromegaly and narrowing of the vaginal opening. MRI revealed pelvic mass 15 by 14 centimeter, solid and cystic components. Also, enlarged para-aortic lymph nodes was noticed by MRI. Also, the uterus couldn't be found. So, no uterus by MRI imaging. Okay, blood test. FSH is high, 53. LH also high, 36. Estradiol is lowered, is less than 10 picogram per milli. Also, some tumor markers are elevated like beta HCG, lactate dehydrogenase, and CA125. This is our case today. So, what is the possible diagnosis What is your comment about this case? What is the management of such a case? Okay, what is the possible diagnosis? This is a case of primary amenorrhea, yeah? What else? This is really a case of mixed gonadal dysgenesis. Why? Why mixed gonadal dysgenesis? Because there is a problem in the development of external genitalia. The patient has a short stature, has a primary amenorrhea, has abnormality in external genitalia like clitoromegaly and narrowing of the vaginal opening. Also, the patient presented later on in her age of 23 by pelvic tumor, which is a gonadal tumor. So, to complete my diagnosis, I should say mixed gonadal dysgenesis and the gonadal tumor. So, in this case, our case is short stature, 150 centimeter, has a clitoral hypertrophy and the narrowing of vaginal opening, and has a primary amenorrhea, and all this suspecting mixed gonadal dysgenesis. Mixed gonadal dysgenesis. Also, the proved pelvic tumor would be gonadal tumor. What's your comment in this case? Okay, difference in sex development is a group of rare conditions involving genes, hormones, and the reproductive organs, including genitals. It is essential for gynecologists to understand the concept of differences in sex development, as they will have many opportunities to treat adolescent women for primary amenorrhea. Any gynecologist will face this problem, adolescent girl with primary amenorrhea. So he should be aware about the differences in sex development and these disorders related to genes, hormones, reproductive organs. Okay? And the delay in diagnosis in this case resulted in development of malignant gonadal germ cell tumor, and this is very important, by the way. This case was diagnosed late because when she was examined at the age of 18 because of primary amenorrhea, the diagnosis should be reached at this moment. But because the doctor who examined her is not aware about the differences in sex development, or maybe not aware about gonadal dysgenesis, he didn't diagnose the case. Okay? So this case diagnosed late. What is the complication happened due to this late diagnosis? Is the development of gonadal tumor. Because this genetic gonads is a risk for development of gonadal tumor. Okay? What else? In my comment, the presence of Y chromosome sequences in gonadal dysgenesis patients increase the risk of gonadal tumor formation. So if this lady has a mosaic karyotype 45X and 46XY mosaic, okay? This Y chromosome increase the risk of gonadal tumor formation, okay? And this Y chromosome also is responsible for SRY gene, which produce Mullerian inhibiting factors. That's why this lady has no uterus. And also is responsible for the Sertoli cell is responsible for Mullerian inhibiting factor, while the Leydig cell is responsible for the production of testosterone, which has an effect after changing to be dihydrotestosterone, causing clitoromegaly and so on. So, this under the effect of SORY gene, which is present in Y chromosome. Also, presence of Y chromosome, as I said, in gonadal dysgenesis, increased risk of gonadal tumor. And you should know that risk of tumor onset is 3 to 4% at age of 10, 10 to 20% at age of 15, 46% at age of 40. That's why when you diagnose mixed gonadal dysgenesis, you should do gonadectomy, because there is high risk of gonadal tumor. As I said, 3 to 4% at age of 10, 10 to 20% at age of 15, 46% at age of 40. What is the most common gonadal tumors? Benign gonadoblastoma is the commonest. Some germ cell tumor, dysgerminomas, seminomas are also frequent. The risk of developing gonadal tumor is higher among phenotypic female and ambiguous genitalia mixed gonadal dysgenesis cases than in male type cases. And this is our case today. She is phenotypically female. She has a higher risk of developing gonadal tumor. She has an ambiguous genitalia, and she is a phenotypically female. In order to prevent the formation of malignant gonadal germ cell tumor, diagnosis as early as possible, followed by prophylactic bilateral gonadectomy is necessary. And this is what is not happened in this case, because there is a late diagnosis. When she was examined at 18, a wrong diagnosis was reached, like acyclic amenorrhea. When later on at the age of 23, the diagnosis reached, maybe, but after development of complication, which is gonadal tumor. So what is the management of such case? First, you should do chromosomal karyotyping. And in this case, karyotype may exhibit, for example, 45X and 46XY mosaicism. Exploratory laparotomy for gonadal tumor, pathologic diagnosis of the tumor, do debulking surgery involving bilateral gonadectomy and resection of disseminated peritoneal lesions, plus or minus chemotherapy. And you may start, if the case is complicated or advanced, you may start with chemotherapy, then do laparotomy and the debulking surgery. Or if you did debulking surgery, you can, according to the stage and the type of the malignancy, you can give post-operative chemotherapy. What else in treatment? Notify the patient regarding mixed gonadal dysgenesis and take her decision about her future sex. In such case, the patient may choose to be a female, to continue her life as a female. Okay? But you should notify her about this problem of mixed gonadal dysgenesis and take her decision about her future sex. Then you should give her hormonal replacement therapy, like what? Like estradiol and norethindrone acetate in the form of patches or pills and so on. Notify the patient about surgical options for clitoromegaly and vaginal stenosis because of improving her sexual life. So, notify her about the different surgical options for clitoromegaly and vaginal stenosis. And don't forget the psychotherapy of such cases because it is very important. Okay? This is a very important. Psychotherapy is very important in such cases, and the doctor should be experienced in such cases. This is as regard the treatment of our case today. I hope you covered the diagnosis, the comment, and the treatment very well. Thank you, everybody. Wishing you all the best. This is my box, published on Amazon, textbook of obstetrics, textbook of gynecology, contraception and book, multiple choice question book, medical disorder in pregnancy, and the gynecologic oncology. Wishing you all the best. Bye-bye.